I'm Edmund Coyne from Mount Sinai School of Medicine in New York City. I've been doing thoracic anesthesia for like around 40 years, give or take, more or less. So I'm still learning. From each case, you can learn something, I can tell you that. I mean, sometimes I get fooled myself with different things. Okay, so this is our hospital, and you're all welcome to come. We have close to 100 operating room, very busy. We have busy thoracic, cardiac service, and so forth, so you're all more than welcome to visit us. We actually have the largest residency program in the country now, in terms of number. So, let's see if I can make it going, this thing. Yes. So this is me when I started anesthesia. I remember that. So, that's about the way it feels like, at least, okay? Let's see if it's going. So what I'm going to talk today, I try to condense as much information as I can. So if I, went too far or too fast, I apologize in advance to it. And by the way, if I'm showing you the first half an hour going to be on lung, method of lung separation, we have a thoracic workshop at 10:30, just in room 217, A and B, three room from here, and you're all welcome to participate if you like. And all what I'm showing you here, all those devices are going to be on tables and stations that you can try one and see one if you like to, if you're interested in. Okay, so I'm going to start about lung isolation, the main thing that I want to talk about, like half an hour on that. And who's going to tell me what I'm looking at now? One of you must tell me what it is, right? It's not a regular double lumen tube, right? Anyone? You can shout, it doesn't cost any money. You see these things? So this is the original Carlin tube, right? It had a carinal hook. The reason I'm showing it to you, I'll tell you why later. This carinal hook, because at that time Carlin for Karolinska Institute, they did not have actually fiber optic scope at that time, in 1948. They didn't have it. So they have this tube with the hook, and you put it all inside until it stops. And that was the original Carlin tube. It's also made it differently designed inside. But that hook was eliminated later by the design of obviously by the Robert Shaw design. The Carlin, the white was right-sided Carlin, because obviously they want to stay away from the right upper lobe ventilating port. That's why the Carlin was originally a left-sided tube, not right-sided tube. The Robert Shaw design that we all use today, the original Robert Shaw was red rubber tubes that you use 300 times. And now we have all this disposable PVC, which is a Malicron, Sheridan, Rouge, Bodex, Fuji. They're all the same. It's just preference of what you use, but they're very similar. This is like the Sheridan Malicron. In the United States, Malicron have basically the market. In Europe, it's like more Rouge. So it's all depend, but it's essentially is the same thing. The all tubes have tracheal lumen and bronchial lumen. So it's like just a preference of the institution and how much you pay for it. But there are different tubes. They are not the regular tubes. That I'm not going to show you just the regular tube that everybody knows as thoracic anesthesiologist. But there are other tubes like Silkerbronch that have an anal tube, reinforced like an anal tube that doesn't kink when you go in. If the takeoff of the left main bronch is acute, specifically after the patient come back for re-op, and he had in the past left upper lobectomy, so the right lower lobe, the lower lobe of the left side expand and turn up. So the bronchus take like 90 degrees only from the trachea almost. So if you put a regular tube, will kink. That's why it was designed as Silkerbronch. And there's other tube here, by the way, this you can look at this is my publication in ANA, and it's a whole thing about those tubes if you want to take a look at this. But I'm going to go over this tube a little bit better. So this is the Silkerbronch. It is having flex. This doesn't kink if you really, the takeoff of the left upper lobe from the carina is very acute. So you want to, it's much slicker if you need to change it over tube exchanger. It's easier to use that tube than the regular PVC that we use. This tube, the paper wash tube, it is, in England, it's not approved in the United States. It's a single lumen tube divided in two in the middle, and the tip sitting like this in the carina. And there are pre-measured blockers that are there, and you can put it right or left. So, but it's a single lumen with one cuff only, okay? And this is the tip of it that sits on the carina. This is the red rubber originally of Robert Shaw that now is available in a disposable tube, right, for one use only, because in the United States you can't use anything again, only it have to be all disposable. This tube, I'm not sure any of you saw, it's a tube that have electrode on the tracheal cuff. And by the flow in the aorta, the impedance flow in the aorta, it gives you continuously the cardiac output. So it's still, I think, under investigation in terms of FDA approval, but it will come, I guess, shortly in the market. So it's very important for you, all of you, to make sure you know the anatomy. Specifically distinguish between the main carina and the bronchial carina. Sometimes people are in the bronchial carina, they think they're on the main carina. And what is right, what is left, the best things to do is to look at the right upper lobe. That's the way, because sometimes the lateral position with secretion and so forth, you might lose your landmark. So this is, I show you, let's see, I hope this video works. Yes. Oh, hallelujah. So this is, you can see the C-rings that are incomplete in the back, and this is, the best thing to do is to look at the right upper lobe. And this is the only lobe that has this segment in the lung, so it's easy to identify. Then you go out and you want to look at the left side and identify the bronchial carina. So once you get this, you study this, I'm going to the left side, and you can see the upper and lower. Okay, so when you put a double lumen tube, you all know you want to see this little blue semilunar cuff. Why? Because initially you thought that if you put a tube that could ventilate to the tracheal lumen, you're not going to block the left upper lobe with the tip of the bronchial lumen of the double lumen tube. And it's found out you can. It's dependent on the size, because the distance is not what you thought. So that's why the best things to do is to put a double lumen tube, and just to make sure that you can see the tip of the tube. So here we're going to go in through the tracheal lumen. This is the carina. I don't see the blue cuff right there. First of all, I want to make sure that I'm looking at this is right, this is left. So I'm going to go, usually it's too deep, but you want to make sure it is in the left side as we assume so. So we're going to go out, take a look to make sure this is the right upper lobe. So I know that the tube, my left side of the tube is in the left side. Then I want to pull it back to see the tip of the blue cuff. Once you do that, you actually, okay, I never actually look through the bronchial lumen after I see the blue cuff, personally. I think I'm okay, unless the patient is really, like 4 feet tall or something. Otherwise, you can do. So you see the blue cuff right there, so I know I'm good. Right-sided double lumen tube. How many of you like to use right-sided tube? Not many, down in the back, yeah. Well, Mallinckrodt, who they sell about 40 left side for one right side. So just to let you know that main use is the right side, is the, what did I do here? Okay, it's the right side. So there are different type of right side. They're similar in design, doesn't matter, it's just a preference what you use. But the whole idea is to have access to ventilating the right upper lobe. That's the whole idea. In fact, in Mass General, they publish a paper, they use right-sided tube for all left-sided procedure, or either vice versa. And they show that it's actually the same thing. They can manage the patient well using a right-sided double lumen tube. But there are times that you need to use right-sided double lumen tube. For example, if you have this, a thoracic aortic aneurysm that's pressing on the left main bronchus. If some colleague come to me, I'm trying to put a double lumen tube left side, and the left side doesn't want to go. And what are you doing? I'm doing a thoracic aneurysm. Well, if you want the case to be short, you can insist of doing it because you can rupture the aneurysm and go home. That's going to be one way of managing the patient. But you want to stay away from that. And this is here. You see the aneurysm right here on the left side. You put the right side of the double lumen tube. And if you have a tumor occluding the left main bronchus, obviously you can put the left side of the tube in that tube. This is a cross section of the lung, and you can see right side of the double lumen. This is the carotid, left, right carotid. This is the right upper lobe ventilating port, and the ventilating port in the tube, and the right side of the tube against it. So it's not always easy. This is looking at down the bronchus intermedius, and this is the right upper lobe. So you needed to really adjust it exactly, not only in and out, but 360 degrees. Also, the double lumen tube are actually bulky. You don't realize how bulky they are. A smallest double lumen tube is much larger, is 35, much larger than 8O tube. So you don't realize, and they're not so friendly sometimes. You can have a laceration of any one of you have ever laceration of the lung with double lumen tube? But you didn't put enough. It's very simple. It's like you ever in the past, before having ultrasound, did you ever hit the carotid when you had put it a central line? Well, you didn't put enough central line, but you're going to hit the carotid one time, not today with the ultrasound, but before. So this is most of the laceration will occur actually when the left-sided tube take the turn to go into the left main bronchus. So this is laceration actually from our institution that you had in this case. You remember I told you the tube with the hook? Mallinckrodt for one time wanted to reintroduce a disposable double lumen tube with a hook. Okay, and this is a glide scope view of you can see the vocal cord. The guy tried to put a double lumen tube. Now you can see here, nice mucosa, any laceration, nothing, any ecchymosis, nothing, there's no blood, nothing, nice and clean. Now, I'm trying to see here, he's trying to put a double lumen tube in, and you can see here that the double lumen tube is actually pretty, right there, it's already created a problem in the mucosal damage. Now, we're trying to put it in. Most of the time, if you cannot put it in, it's because it's engaged in the anterior part of the trachea or engaged in the left vocal cord. So what you do, here you try, this is the hook that I'll show it to you better. You can see the hook right here, the blue piece. So you try to move it, turn it, to go through the vocal cord, but look how much damage you have over here already, right? The best thing to do is to go turn it clockwise, and once you do that, you turn it counterclockwise to go inside there. I turn the tube to go to the left, not only 90 degrees, but I turn 125 degrees. I put it more because then when you have 125, you push it in, you are most likely to go to the left side. So most of the teaching is to, once you go in, you turn it 90 degrees to the left. I'm talking about left-sided tube, right? You push it in, but if you go to 125, you actually have more chance of going inside to the left side. Okay, so again, the mandatory time that you must use the double lumen tube, and obviously, if you can see, it's like when you need lung isolation. In other words, when you want to isolate the healthy lung from pathology of the diseased lung, such as hemoptysis, empyema, lung lavage, you can't use a blocker. It's not going to work. Lesion of the main stem, of course, you can't put a blocker on the left side. If you have a lesion there with the blocker, you have to go to the right side of the lumen tube. If you have sleeve resection, this is an open airway. You can't use a blocker right there. You have to do double lumen tube and a tracheal bronchus in a minute. Otherwise, all the other you actually can use it just for surgeon comfort, and you can use, I use personally 9 out of 10 cases broncho blocker. How many of you use broncho blocker here? Nice, I like it. Anyway, so I think I'll show in a minute why about it, why I think you should be part of your normal toolbox. So what is this, young lady here? I just told you what it is, right? What is this here? This is the right upper lobe comes from the trachea. You see, this is what you call, this is normal in pigs, actually. So the pig trachea. You can't put the blocker there. You have to put it up a little bit because you cannot block this side with the blocker. So let me show you something new. Did anybody saw this tube? If you come to the workshop, you see it. This tube, they don't allow you to put names, so I can't tell you the name of it, because they try not to have any commercial name. They give you a whole instruction when you put in the slide. You have to take the name off. But it's what I call it, it's a carinal balloon. Okay, the tube with carinal cuff. You see it has this green cuff here? So what the idea is, this tube, you put it inside, and then you inflate the green cuff, and you push it in until it stops. And once you're there, you deflate it to be able to ventilate. So essentially what it does, it tries to rebuild the original. You remember I showed you this Carlin tube, the first slide? It just rebuilt the hook. It's just a hook that just go, once you intubate, you put this green cuff up, and you push it in until it stops. So that's one of the tubes that it's available actually in, it's available in commercially FDA approved, and it's marketed. You can come to see the workshop, you'll see it. The other interesting tube that actually have FDA approval, and I'm not sure any of you saw it, but it's still not, I'm not sure it's marketed yet, but it's FDA approved. This tube you call SOLVE. So S stands for simplified. OLV, one like ventilation. E for everyone. So that's why they call it SOLVE. Okay, so what is this tube? It's interesting. So this is a one tube that you can use right and left. Thinking that this cuff, the bronchial cuff, is short, and it doesn't matter if you put it in right or left. It's the same tube. So if you took it like this, it stay right there in the right, and you can put it also in the left. So they are claiming that this tube, you see, that's considered right side. It's the same tube. If you turn it, it's the left side. So they are claiming that it's short enough to put, the accommodate between this 1.8 millimeter between the carina and the take off the right upper lobe. Well, it's not always the case. Sometimes it's much shorter. But they're claiming that that's what it can. In fact, they show you even pictures. This is looking in the left, and then you can see in the right main bronchus, you can see through the, this is looking through the tracheal lumen, this is the bronchial lumen, you see the right upper lobe. So, and this is the bronchus intermedius. So you can really, they're claiming that you can put that tube in the right side as well in the left. So you don't have to think right and left, 1 tube fit all. So, but the interesting thing about this tube, something totally different, is this. What I find it very interesting, when you put a regular double lumen tube, you know, it's a 2D-shaped lumen that put one in the other. When you want to put the fiber optic bronchoscope there, it would not accommodate more than 4.0 fiber optic scope, right? If the surgeon wants to do bronchoscopy with a 6.0 bronchoscope, he cannot really do it with a double lumen tube because it's too, it would not fit in the lumen of even of a 39 or 41. That tube that they have, they show you, have something interesting. Have a soft division between the tracheal lumen and the bronchial lumen. It's soft, and you can actually accommodate, because it's soft, you can put a 6.0 tube to there, to that double lumen.
So that's an interesting device to see. I think it has some merit because, in my opinion, I have no stocks in it or anything like that, but I think the idea, many times some surgeons want to do, pulmonary toilet and they want to see better with the scope. You have to take the tube and put it back in. Every time you do that, you risk losing the airway, you know that, right? So I think that has some interesting part. And remember that the criteria for putting a double lumen tube are not the same for single lumen tube. 10% of the time you can put a single lumen tube, you will not be able to put double lumen tube, depending on the tongue, the teeth, and so forth. And if you want to change the tube, the airway at the end of the case are not the same at the beginning of the case. Because secretion and edema, you might think it's okay, you want to change the tube, you lose the airway. All you need in your life to lose one time the airway in all your career, you'll never forget that. So that's something you keep in mind. So bronchial blocker, I like blockers, there are different types. Again, it's preference. I'm not sure if you saw all of them. You can come to the workshop and see them. I changed the name to a different name, snare blocker or deflecting blocker, and so forth. The bend tip blocker and so forth. You can see the name of it. This is, for example, the snare one. You can put the blockers, on the fibroscopic scope, the snare, and you can slide the blocker over the fibroscopic scope. The fibroscopic scope will serve as a guide to it. This is the way you put it here, and it comes through multiple adapter. I'm sure if you use the thoracic anesthesiologist, you used it in the past. This is the flexi-tip one that have a wheel. You can turn it, and the tip flex. You can put it the size you want, like this. And it has also a landmark, like a sign, a black arrow that tells you which side the tip is deflecting. And here I can show you here, when you go in, you see the black arrow here. You turn the wheel. If you want to go to the left, or usually go to the right automatically. You want to go to the left, you turn the wheel, and then you can put it to the side you want, in the left side. Once you turn the wheel here, the tip will deflect, and you'll be able to put it to the side you want. So you have to just try it yourself to see it. This one is like a hockey stick. It's a full. I like this blocker because you can ventilate with this adapter while you position it, much easier than the other one. This one has two heads. Anybody saw this the blocker before? Yeah. So it's some institutions it's pretty popular. It doesn't matter where you have two heads. It doesn't matter where you go. If you can hear, I can show you. Go inside, and let's see if it works. Yeah, you can put inside, and it's open, and you can put it. You can deflect selectively the right or left in this side. The key in this one is that you want to have the tube, the tip of your and of your tube, the single lumen tube, at least 3 centimeters above the carina. Otherwise, you push it in, it's going to go both to the same side. But what's good about it that I like, and we used it a couple of times recently, because if you have massive bleeding, you want to put a blocker, you can't see anything. So blood all over and stuff. This one you don't need to see. You put it in, it's, go to one side, you try clinically to see. So it's good for bleeding, and you cannot really see with the regular scope. The problem with this, if you're going to use it just electively, every time I touch it, it does this. Electively is that you cannot suction through that lumen. This tube is only 7 French wide diameter, and it's already split in 2. So you can't really suction through this in terms of suctioning. Okay. If you have a double lumen tube, you want to change it to a single lumen tube, don't do it blindly, unless you want to call your lawyer before you do that, because then you can lose the airway. The best thing to do is use one of the tube exchanger that's available, and you can use them. When you use a tube exchanger like this, you want to make sure to know which one goes where, in vitro before you do it in vivo. The tube exchanger come in 11, 14 and 19. The 11 goes to all of them. The 14 doesn't go to 35 and 37. The 19 is only single lumen to single lumen. So you want to make sure you know that. Blocker one light, you avoid changing it to one light, one size fit all. If you have a difficult airway, put the single lumen, put the blocker through put the double lumen through a tube exchanger, or you can put the blocker. If you have a patient with pharyngeal, give us some cases why I think you should consider in your mind to be able to use a blocker. If you want to use a blockers, you want to make 50 of them at least cases electively. Don't try to be a case you must use a blocker, you can't give me a blocker. You're going to lose you're not going to be successful to do that. You need to do it electively, not when you must do it, otherwise you're not. And this one, for example, a patient have all this tumor that you can't really, we were happy to put a tube inside, imagine double lumen tube. If you have a patient with tracheostomy, in Europe they have this small tube that you use for tracheostomy, you can use. It's not available in the US, it costs about 500 euro. One time I got one of those to bring it here to use it, and my dog thought it's a toy, so he ate all the cuffs. So that was the end of that. But you can put a blocker actually, so a Charlie tube, you can put a blocker through a regular tube, you can have a blocker next to another tube to the trachea, and you can see it here, that we have a blocker going to the, you can see it here, we put a blocker next to it, we're blocking the right side, and this is the right upper lobe, and you can see, and you can use it, so you don't have to put it up. It's difficult to put double lumen to the trachea, so the stoma of the trach. Patient who require nasal intubation, right? You're not going to put double lumen tubes to the nose. It's kind of traumatic to do. Patient who is kyphoscoliosis, patient who is obese. This lady was 650 pounds. Can you imagine putting a tube and change the tube 2 times on her? We put a blocker, and I don't want to try to change tube on her a couple of times, so we put a blocker to her, and we did it. Once the pediatric, they come in pediatric size, 5 French. If you need to, we actually have a pediatric station in the workshop. A patient who intraoperatively require lung isolation. The patient said, I don't need one lung ventilation. The patient in the lateral position, it's small. Well, actually, I need it. Now what are you going to do? Change the tube in the middle? Or the patient come from the ICU for a little biopsy, and he had dermatose and intubated. You want to take the tube, put a double lumen tube? No. Put a blocker and do it. So they just give you some idea why you want to do this. But when you use the blocker, you want to make sure that don't go the peak airway pressure above 30. Because at the peak airway pressure above 30, the cuff of the blocker is a high volume, low pressure. So air will go around it into the lungs, okay? So you want to do that. Because you can see that this little poor thing block the air going out, unlike the double lumen tube. And the right side, I think I missed it. And the right side, you want to be very close to the carina to block also the right upper lobe. This is a tube that you can see in. You have a camera in. Anybody saw that? Use it? Do you use it routinely? Yeah. Have the camera in, and you can put like here. I can show you. This is a tube. You can see that's what you should do. The tube disposable, has a camera. You can put a blocker inside. You don't need fiber-optic bronchoscope to do that. You can do it what you want. It has also a double lumen tube right there that has the camera here, and you can continuously see the position. I said at the left, the tip of the blue cuff right there. You can see it continuously to see if it moved during the case. But double lumen tube, mainly 80% of the world use double lumen tube, not blocker. And this is because surgeons want double lumen tube, they're used to it, and because also most anesthesiologists are not comfortable with blocker compared to double lumen. We use double lumen tube for more than 50 years. Well, my opinion about it is, this is a car that I had in Opel. I was a medical student in Florence, Italy. and I bought this car for $50. Well, not this one exactly, but this type. And the reason why I gave them $50, it would have, you know, shift, 1, 2, and 3. It was stuck on 2. That's it. So nobody wanted it. I said, I'll take it. And we went with this car from Florence to Paris. It died in the middle of the Alps because I burned the engine in 2 instead of going to 6. So if you want to drive this car, not be able to change one, I was able to stay on 2 only. If you want to drive a Ferrari, that you can go 1, 2, 3, and 5, try to put it in your toolbox. Because for me, just using a double lumen tube, you're stuck to one thing. You want to be versatile, be able to use clinical management according to the clinical situation, according to the patient need, according to what happened if it's a difficult airway, you need to post-operatively to be again ventilate the patient in the ICU, and so forth. People say that blockers, are not as good as double lumen tube in work. So this study comes from Peter Slinger group from Toronto, and what they did, they used 4 groups, those 3 blockers that are in the market plus a double lumen tube. So 4 type of groups, and the surgeon, they were out of the room, they were blinded to what type of tube device given to them to isolate the lung. One of those 3 or a double lumen tube. And then they asked the surgeon to grade the quality of the lung collapse after 10 minutes, 20 minutes. What do you think the difference was? Nothing. This is the surgeon. They didn't know what it is. They actually graded it exactly the same. So if they're telling you it's not, don't believe it. And this is another study, actually come from Canada also. They use the well collapse, not collapse, and grade it, and then it's the same thing come to say that they said the blocker did better. I don't believe it. But this is a study here from Poland. They look at it's about, I don't know how many, 1,636 patients looking at meta-analysis of blocker versus double lumen tube. And this is all the studies they looked at in the whole list of studies that they did. And they find what? That excellent and fair was exactly the same in all those studies. It didn't make no difference between in the study itself, the meta-analysis of it. It's actually they concluded that you have more hypoxemia with double lumen tube, there are more hoarseness, more sore throat, and there are more injury in the double lumen tube compared to blocker. So don't believe what they tell you. That just use your own judgment for it. And again, double lumen tube are the gold standard. And if you use blocker at the learning curve, and if you want to use it, not when you must use it, okay? And you have to have it part of your toolbox, in my opinion. That's the whole idea that I'm telling you in the first half an hour. And you have to use what you're comfortable with. That's what you're comfortable with. That's what the best thing to use. I'm going to go to change the next half an hour on the management one lung ventilation. When you ask you how I ask my resident, what is this percentage of shunt during one lung ventilation, they tell me 20, 30, 40, 50, all kind of number. You want to make sure that you realize what to do. And normally in the lateral position, 2 lungs, you have 40% flow and 60% down, gravity dependent. If you consider 10% shunt, you divide it between both lungs, HPV will divert half of the blood of this 35 down. So you have about 22%. Add the 5% shunt that you have originally here, you get about 27% shunt. That's usually the shunt you have, about 27%. And the reason why it's good to know, because once you get the shunt above 30%, increment in oxygen FiO2 will not increase the oxygen partial pressure anymore once you do that. So keep it in mind. Actually, today we don't see much hypoxemia like in the past, and I think because we use fiber-optic bronchoscope and use protective lung ventilation. The bad thing, one of the pulmonary complications it's a high number of pulmonary complications. And they're associated with unplanned ICU admission, prolonged admission, increased mortality. And you want to avoid all with your ventilation, your management one-lung ventilation, to avoid all this pulmonary complication. Atelectasis is the #1 complication we have in after thoracic surgery. And even you try to minimize this complication by minimally thoracic surgery, minimally invasive, fluid, careful fluid administration, lung separation, and so forth, and protective lung ventilation, low tidal volume, PEEP, and recruitment maneuver, the 3 parameters. Still, you have up to in some studies, up to 45% of the patient have some kind of pulmonary complication. And in thoracic surgery, because of the lateral position, because of this lung disease, manipulation of the lung, and so forth, you always end up with atelectasis. And atelectasis usually we cannot see with X-ray. You need to CT scan because they're always in the lower part of the lung. When they are, you can see it. I'll show you here, this patient lying here. If this patient is breathing spontaneously, the head is here, this is the diaphragm. Okay, head is here, this is the diaphragm. And if you non-paralyze the patient breathing spontaneously, okay, this is the patient breathing spontaneously. You can see it here, right? The patient is nicely breathing. Most of the ventilation goes where? Down here. You can see it. Also, this is dynamic MRI, and you can see the patient is breathing right here. This is where because the diaphragm is not paralyzed. Okay, and down here you can see nothing. There's no atelectasis nicely. But when we paralyze the patient, now in paralysis, you see how it shifts up? Now the ventilation shifts up to the top, not down anymore. Most of the ventilation compared to here. And what do we have here? Atelectasis. So don't fool yourself. Every time you put the patient to sleep and you paralyze him, you're going to have atelectasis in the lower part of the lung. That's why we use high FiO2, that's why we use PEEP, that's why we use the recruitment maneuvers in order to avoid that. Let's see, okay. Good. So the goal actually is to minimize the lung collapse, and the idea today is that you have open the lung and keep the lung open. That's what you want to do. And the 2 things to do it is alveolar recruitment maneuver and PEEP. Now, PEEP has to be individualized because the problem with PEEP is a whole story about it. That's always work because, I have one jacket. If I want to give it to him or to him, he's a skinny guy, not like me. I need a larger jacket. So one jacket doesn't fit all. PEEP doesn't fit all. One value of PEEP is not good for everyone. So you have to be individualized PEEP. That's the all recent things about. So let's see if you don't use individualized PEEPs. So this is a study, the Provil study, that almost came out several years back. They took 2 centimeters of PEEP in over 400 patients. This is prospective study. Took several years to do. And the other group of patients have 12. You see, and you would say probably higher PEEP is better, isn't it? We're giving PEEP to the patient, we're opening the lung. But this is not individualized. They put it across the board of this patient doesn't matter how much you weigh and what you are and so forth. What was the result? Nothing. They're exactly the same. The postoperative problem was exactly the same, no different whatsoever. Didn't make a difference. Use 2 of 12. And this is, you can see, that you don't see double. This is it. They're exactly overlapped. Then you come and say, well, but in obese patient, that will make a difference, for sure, right? It makes sense because normally, if you put the same thing with obese patient, so they have the Provil study, the PROB study, the PROBES study, I apologize, PROBES study they call it, and they use the same thing with 12, they put 4 centimeter versus 12, not 2 and 12, and they, again, in almost 1,000 patients in each group. This is prospective study. And you would say in obese patient would make a difference, isn't that? What the answer is no.
It's exactly the same. Didn't make no difference in terms of postoperative complication. So if you don't apply individual PEEP, it doesn't make a difference. You have to be individual PEEP. And the best PEEP is what is the lowest driving pressure. That's the best PEEP. So how you divide individual PEEP? Well, it's not, is you want to maintain, the individual PEEP maintain the patency of the alveoli, it improves the end respiratory lung volume, its oxygenation is better, it tells better to physiology of the lung and so forth. So how do you apply? You can do it at the compliance bath. You can do it by decrement PEEP after recruitment maneuver. That's usually the type of PEEP that we do. We do recruitment maneuver, then we do decrease the PEEP until you find the best PEEP for the patient. Or you can do driving pressure guided to see what is the lowest driving pressure to the lung. Or you can do with oxygenation guided. But sometimes, if you can do a esophageal manometer to see that, or you can do electrical impedance tomography. So that's something you can do here. I'll show you this. This is, for example, impedance. Can't do it really in thoracic because you need a belt on the chest, but here we're going up. You can see here, you increase the PEEP until you open this impedance, and you increase the positive until the lung is open. And when the lung is open, it's decreased. The peak pressure decreased. So that's external impedance tomography to use if you can, if you have it, to use it. So is individualized PEEP make a difference, right? Okay, so this study published in Medicine in 2021, a couple of years ago, and they use a large number of patients. This is, again, it's a prospective study. And they look at this here. They use electrical impedance, esophageal manometry, and they use all those three things. Actually, it's a meta-analysis. I apologize. Meta-analysis use look at all the three ways of you put individual PEEP, and they find that actually they find 848 patients that use individual PEEPs in the studies, and they find actually lower complication, post-operative complication. Partial pressure of oxygen intraoperative was better, higher oxygenation index. So it's making it different if you use individual PEEP in that study. Recruitment maneuver, remember to do that, it's very important. This is, for example, I'll show you. This is the atelectasis of the lung. 1, 2, 3, 4, 5, gun, right? You put it up and show it to you how it's gone. So this is an important thing you want to keep in mind to do. Now this is recruitment maneuver. This is alveoli of the lung. And if you see, I'm going to start putting it up in the side here. There's a volume pressure curve. And you look at the alveoli and start giving positive pressure to recruit those alveoli. Oh, you can see that. They're all recruiting, this are pumping up. And you can see up to here. Now, this is the point that you want to stop, because now you get volar trauma. You don't want to go exact. So this is the area, and then you can go down. But this is the recruitment maneuver that you open the alveoli, open the lung, and keep the lung open. That's basically the whole idea. Tidal volume. Tidal volume, the way I see it, is this. It's a chaos. Okay, because there's a whole story about tidal volume, what to use and when to use and so forth. So if I ask any one of you here, what tidal volume should you use? You tell me, 4 to 5 millimeters and so forth. Well, this comes from the New England Journal of Medicine, in 2000, 20 years ago, that they stopped the study. They used 6 ml versus 12, and they stopped the study after 800 patients because it was not ethical to use a high tidal volume because they have more complication, more mortality. So that's why you do all the time, use protective lung ventilation, low tidal volume, PEEP, and recruitment maneuver. But is this the patient we see? Those patients all ARDS. The patients that publish in the New England Journal of Medicine, our patients don't have ARDS. How many patients? Most of our patients are patients who come to find a coin lesion in the lung, just like this. So it's a different type of patient. Let me just show you here. Initially, we have all the issue on baby lung. You know the concept, anybody know what I'm talking about, baby lung? This baby lung concept was introduced by Luciano Gattinoni from Milano. And what is, it started to say, so if you have a area of ARDS you can recruit, you should treat that lung as a baby lung, because if you give normal tidal volume, the other part will expand so much, you have trauma. So you have to lower your tidal volume. And then we have the whole concept of open lung, right? Open lung thing that we say keep it open and keep it open, and then the protective lung, mechanical power, protective lung ventilation. So this is the baby lung concept. If you have a normal atelectasis, okay, use 500 ml, you have a stress index of 1. If you have part atelectatic, the blue part does not expand, and you use the same 500, you have a stress index much higher. So you really need to go down to 250 in order to keep your stress index of 1. Okay, so that's why the concept of baby lung. And many studies shows you here low tidal volume, and this is a study by Foutier in the New England Journal of Medicine. They use 10 to 12 ml per kilo versus protective lung ventilation. But they use they use 10 to 12, no PEEP, no recruitment maneuver. Who would do that? They use like total disaster versus protective, so they find a better number. I mean, I don't know, but they publish in the New England Journal of Medicine. That's ridiculous. But anyway, they have 25 to 10, but they are Foutiers from Montpellier. Montpellier, they think they are the best in the world. People in France, actually, you cannot practice medicine in Montpellier for many years if you didn't graduate from the University of Montpellier. You have to be graduate from Montpellier in order to practice in Montpellier, because they thought they are the best. Maybe that's the residual of those thoughts. I don't know. Don't tell them I said, don't record me, please. The other study here that looked by Ari Septoneto from Brazil, in 2,000 patients, and again, they find it much better with low protective lung ventilation. You can see it here. But again, no study until today show you that tidal volume by itself is okay. It has to be accompanied by other things, not just tidal volume. And this study, again, I'll show you here. This is by Peter Slinger, meta-analysis, and they looked at systemic review of how many? 3,600 something patients, and they find the oxygenation didn't make no difference, the compliance didn't make no difference, length of stay make no difference, a little bit different in pulmonary complication. So this, they find slight decrease in pulmonary complication when you use low tidal volume. This study here looked at the whole tidal volume issue. This is a large study of 6 ml versus 9 ml, and it's like a large number of patients, like 500 patients in this group, prospective study, and you would see if they make a different low tidal volume versus high tidal volume. Well, what the result, again, you don't see double. It's exactly the same. They make no difference in terms of any 90-day survival, ICU stay, and length to stay in the hospital. They make no difference with all three of them. Now, in our institution, we did some analysis of 30-day mortality and to see what is the best one, the lowest mortality. And we find out actually the mortality, the least mortality was 9 ml per kilo, not 6 ml per kilo. So then you come and say, well, this is not thoracic patient. So Randy Blank from Virginia, he went to the surgical data and find 1,200 patients that have complication. And look at this. The lowest was 9 ml per kilo, not 6 ml per kilo. So the fact that you say we're going to use 9 ml or 6 ml low tidal volume doesn't mean that you actually do better with higher tidal volume in thoracic rather than low tidal volume, because that's what the data show. Why is that? I think that one of the reasons is the hyperemia, because when you remember I told you that the shunt is about 27%. That means that other 70% go to the dependent lung. So that lung, all of a sudden, see enormous amount of flow going through that. And one of the things that the lung try to protect, there's microfill. Then the microfill see high flow, it bend. When it's bend, it releases nitric oxide. It's a protective mechanism in order to prevent pressure on the wall. So, and when you release nitric oxide, the tight junction between the cell, you lose the tight junction. So inflammatory factor can go from the blood into the lung. But if you put at that time high tidal volume and PEEP, you maybe deteriorate the shunt, but you reduce the flow of this dependent lung. So you don't have hyperemia. So that's one of the theory behind it. I don't know if it works or not. I'm going to go a little bit faster here because I want to show you a couple of, I'm going to skip all this now because of time. I want to show you something a couple of interesting things here. Okay. Anybody saw this device? Okay, this is something interesting. You put it under the tongue, okay, and you can see the microcirculation in the lung. So this is the microcirculation. This is the red cell flowing in the capillary in the lung, in the tongue, and you can see how the patient. This microcirculation is a huge thing today. That is much more. It's a whole organ. The whole meeting journals about it, and you can see how the patient is doing according to the microcirculation of in the tongue. So one of the things that is important is in the microcirculation is that it's not enough to bring blood to an organ. This blood have to be distributed in the organ in a certain way. If you can see here, this venula. This area is fine, is oxygenating. This area is hypoxemic, okay? Because the distribution of the microcirculation of this organ is variable. It's not exactly the same. So clinically, for example, this is a lady that was 80 years old woman that had the microcirculation here. You can see the red cell, and her blood pressure was 40, mean 40. So they gave her vasopressin in order to improve the circulation, the blood pressure. So the blood pressure went from 40 to 80, and an hour later she died. Now, why did she die? Because look at her microcirculation after you give the blood pressure. Nothing. So you basically think you're helping the patient, you basically shut her circulation. So the microcirculation is an important issue that is now taking a lot of effect, and we're looking at this also in the lung and so forth. The other concept I want to show is the fact, remember I told you what's hypoxic pulmonary vasoconstriction. What is hypoxic pulmonary vasoconstriction? It's a protective mechanism, right? Take away blood from areas that are hypoxemic in the lung and move it to areas that are well ventilated, right? That's what it is. So area of hypoxemia, they take away the blood to an area that's ventilated. Now what happened to the other part of the body? This one here, I can show you. You can see here, this is the blood cells in the muscle. And this is here, look at this. This is the oxygen FiO2, okay? As you look at the plus sign, it's 20. I'm going to make this area hypoxemic. I'm lowering the FiO2 down to hypoxemic area. Look what happened to the muscle, right? It's flooded with red cell, okay? The red cells are coming to the muscle in order to maintain the oxygenation because of the hypoxemic area. This is exactly the opposite of what happened in the lung. The lung tank, now if I get that and I put this plus sign here, back up, right? I'm going to increase the FiO2 back to 21. The red cells are gone. They're going away. So this is the greatness of this HPV. It's exactly work differently the other way around that the other rest of the body. The rest of the blood goes to an area with hypoxemic. In the lung, it's taken away. It's totally different. I still have maybe 5 minutes to talk about something interesting again. Is the lung regeneration. You know that if you need lung transplant, how many of you do lung transplant here? Very few. Okay, so if you need lung transplant, it's difficult to find. Most of the lungs, they're not using it. There's a lot of lungs they don't fit to be transplanted because they're very delicate. Now, what happens if I get someone I can create for a patient individual lung just for him on demand? That sounds crazy, isn't it? Right? If somebody needs lung, I can create one just for him. Right? Sounds like science fiction, not real, okay? So this is, for example, a heart that was created from stem cell in Jerusalem University, and this heart is pumping. It's created after stem cell. 3D dimension, printed, and the heart is pumping, created from stem cell. So you can have a lung that you throw away, you can decellularize the lung, then you put back stem cells, epithelial and endothelial cell, and you put it in some reactor. I'll show you a little bit better. So first of all, you take a lung that you throw away. Lung that you take from a donor, the lung is not good. You're going to throw it out. It's not feasible. You take it, you put it in detergent solution with sugar and stuff, and keep the elastin protein, whatever. I'm not going to go into detail. But what happened to this lung become like this. This lung just have the skeleton. It just, all it has is the collagen 2. All of us here in this room have the same collagen 2. It's not reactive. So I have a skeleton here that have only, and if you go into the skeleton, and I can also do it from 3D printer, I took the skeleton, you can do bronchoscopy, you see exactly the structure of the lung, but it's white, because there's no epithelial cell, no endothelial cell, there's nothing there, just the skeleton. Then I'm going to go and take from the patient, from the umbilical vein, or you take from the fat of the tissue of the patient. That's why I still keep my fat, just in case I need to have enough tissue to do that. And then you could create type 1 and type 2 cell. It's challenging because you have to cover about a tennis-sized court. The lung, the area of exchange between alveoli and everything, it's about 100 square meter. And there's 40 type of cells in the lung, not 2. So it's a challenging thing, but you can put the main thing, the type 1 and 2, you can put it, and then you repopulate that lung. You put it into the trachea and the pulmonary vein, and you put into a bioreactor. This is the lung they put in the bioreactor for a couple of months. And then the lung will repopulate with this endothelial and epithelial cell. And you know, because when you put the lung, you put the denuded lung on a ventilator, the peak airway pressure is high because there's no surfactant. The lung doesn't produce surfactant. And when the cell starts working and produce surfactant, the peak airway pressure goes down. And also you look at the microscope to see the population of the lung. So then that is the lung. This is a rabbit lung. It's not a human yet, but it's a rabbit lung. And this is the lung denuded. This is the lung after it took 2 months in the bioreactor. Okay? Then, so the idea is this: take the lungs you don't want, denude it, put the alveolar epithelial cell, put it in the bioreactor, ventilated there, the trachea, repopulated, it's become red again, and you transplant it to the rabbit. This rabbit was alive 6 months after on that lung. Now, can you imagine when you do it in human, it's incredible that you can really have a lung on demand just for the patient. So the lung is very, some organ. This is You can see the microcirculation of the lung. You can see the red cell going around the alveoli. And it's amazing organ to think. I'd like to think, I have only one more minute to tell you two things. A, that we have a thoracic symposium with the PGA in New York City, just before the PGA. It's the second week in December, always. Bring your credit card to New York, because there's a good sales there at the time. And I don't know why they took me off. They decided I have to leave. Let's see. I want to show you one. I don't know if I can see it now. I think they took it off all over. I don't know how to go back to, okay. I want to show you one more picture before you leave. Okay, who is this? Still have 2 minutes, so. Anyone? Well, this is the Queen of Denmark. So I was there in a meeting. I was introduced. She had her palaces, summer palaces there, where the meeting was the European Society of Cardiac Anesthesia, and they chose 10 people to be officially introduced to the Queen. I was chosen. I don't know why. I chose one of them to be introduced to the Queen. And when they give it to you, before you meet her, they give you a whole instruction. You can't give her anything. There's a guy with uniform standing next to her. You give it to him, and he give it to her. You can't take a picture of her because she smokes, and they don't like it that she smokes. They want to see it. And then the more thing, you don't ask her anything. You don't start talking. You don't come and say, hey, what's up? No. You just answer if she asks you, okay? But the worst thing was, you don't eat if she doesn't eat. Now, I was starving. She didn't want to eat anything. I would tell her, what to get something to eat, you know. It's actually, this is another, if you want to stay another 30-second continuation. They took a picture, they brought it to my hotel. The Royal Palace envelope, this is from the Royal Palace with a picture of her. And then I was actually going to a wedding in Israel. My wife is just here, my wife is here. And my daughter was already in Israel, and my wife and my son was in Israel, and me and my daughter were supposed to go to Israel to get a flight from Copenhagen at 2 o'clock to Tel Aviv, to wedding. I come to the airport, I said, it was that time ticket, paper ticket. And here's it is, he said, she looks at, sir, you're not on the list. I said, what are you talking about? Here's my ticket. He said, yes, sir, that's for tomorrow. So what? They gave me a ticket for tomorrow. The agent, my mistake, gave me a ticket the day after. So when I said, can I go to the flight? No, the flight is full. We cannot do anything about it. Then I have a brilliant idea. I said, do you know who you're talking to? And I said, I just came to meet you. They love their queen. I came just to meet your queen just now. He said, oh, yeah, of course. I had dinner with her now. So I took this picture, and I showed the picture. She ran to the back. 5 people with the manager came out to see who is this guy. He just met the queen. 2 minutes later, I got 2 tickets on the plane. All right. Thank you very much. I hope you learned something, not about the ticket, but